Mechanical thrombectomy has enabled us to achieve hopefully an optimum patient pathway by allowing us more time to offer these patients intervention. Previously, as we know, with catheter-directed thrombolysis, this only worked on thrombus that's less than 14 days old. Actually, by the time these patients get to see us, their symptom duration is usually at least 2 weeks old, suggesting that the clot is at least subacute, if not chronic, by the time we're actually intervening. Mechanical thrombectomy allows us to review the patients in a timely fashion, but not as an emergency. It gives us time to discuss with the patient the option of intervention, and in potentially mild or moderate cases, we may well elect to treat these patients conservatively for a period of time and potentially bring them back for review in 1 to 2 weeks, still with the option of intervention. If we do want to intervene again in more severe patients with more severe symptoms, we have the ability to plan when that intervention is going to take place so that we can ensure we have operating theatre capacity, ward beds, etc. So it allows us to plan these patients' intervention urgently but not emergently to hopefully optimise their outcomes. It also allows us to not make quick decisions on perhaps more complex cases and allow the opportunity for a trial of anticoagulation alone. And obviously, if the symptoms don't improve or indeed worsen, then we have the opportunity still to intervene to treat these patients. So I think it's important to educate your own colleagues and those around, the referring clinicians as well, about what you can offer, because a lot of people don't know that you can intervene for DVT and think that actually anticoagulation, leg elevation is the way forwards. So education is absolutely key. I think having a dedicated team that have an interest in venous work is also important to make sure these patients get the best treatment and best outcome. I think we in our hospital have moved away from catheter-directed thrombolysis for treatment of acute DVTs because this has enabled us to treat more patients. We don't need a dedicated thrombolysis nurse or ITU bed in order to treat these patients. We can manage them potentially even as a day case procedure in some situations, in some cases. So I think it's important to educate those around you. I think it is important to have a clear pathway for these patients with clear anticoagulation protocols, both pre, intra and post-operatively. So we also have a dedicated venous MDT, in particular for more chronic patients, but also more complex acute DVTs will get discussed in that. And that involves myself as a vascular surgeon, my interventional radiology colleague, and our haematology colleagues as well.